I was pleased to have been invited to address you tonight. This is based on a talk I gave to the incoming Dystonia Fellows, and I think a few of the people in the room heard me and suggested it might be a good talk for the rest of you, and so I agreed, and I'm glad that since I was coming here anyway, this is a good opportunity to be able to share this with you. So what I like to do is start at the beginning, which is always a good place, and show you a picture of Herman Oppenheim. Dr. Oppenheim was a very famous German neurologist, probably the most famous German neurologist ever. And he was in Berlin. A lot of patients. He wrote textbooks. There was at least 5 editions of his textbook in German. And the 5th textbook was translated into English, and I own a copy of that. They're rare to find. I'm sure they're worth a lot of money today. And they're still valuable. If you look through those books, you can find things today that amazes us. The neurology of today can learn from the past. Herman Oppenheim has other diseases named after him. Oppenheim disease is a disease of children who were floppy when born. And in 1911, he described and used for the first time ever the word dystonia. He invented that word. Now, he was a German Jew. And when the professorship opened up in his university, he was bypassed because he was Jewish. And he left academics, and of course he had his own practice, and he was very successful even then. But that's the life was in the time of Germany in the early 1900s. So, but he's still famous, and in fact, the first gene for dystonia that is labeled DYT1, I've called Oppenheim dystonia, because he described the conditions that DYT1 is showing. And this is his story, and this is his paper. So published in 1911, that's 101 years ago, and in German it reads, Über eine eingenannte Krampfheit des kindlichen und jugendlichen Alters. I'm not very good at that, of course. Dysphagia lordotica progressiva dystonia musculorum deformans. So what that translates is in English, about a unique cramping sickness observed in children and teenagers. And quotes directly from his paper translated into English. In the course of the last 5 years, I have repeatedly observed an affliction whose meaning and classification caused great difficulties. When examining the first cases, I was trying to decide between a diagnosis of hysteria and idiopathic bilateral athetosis, which is a writhing type of movements. But then I soon realized that neither of these diagnoses was appropriate and that this was a new condition, or at least a new type of condition. The disease has something quite unique, namely the severe tonic cramps, particularly in the neck, head, and proximal sections of the extremities. The unique torqued gait is practically pathological. The prognosis is bad. All therapeutic attempts are as of yet unsuccessful. During my efforts to delineate the methodology of the disease through an incisive name, I have selected the titles Dysphagia lordotica progressiva and Dystonia musculorum deformans, and would prefer the latter. So dysphagia means abnormal gait, lordotica means lordosis, their spine is pulled backwards. Progressive, of course, means the condition gets worse. Dystonia, I'm going to explain what that means in a minute. Musculorum and deformans means deformed muscles. What he said in this paper are still the truisms today about dystonias. Hypotonia at one occasion and tonic muscle spasms at another, usually but not exclusively elicited upon volitional movements. That's what gave the word dystonia. When the muscle tones changes, means abnormal tone, dystonia, abnormal tone. So one times it's tight and other times it's loose. And that's why he coined that term. He also pointed out no paresis, no weakness, no atrophy, no alteration of electrical excitability, no sensory nor perceptives nor sphincter disturbances, no significant psychological abnormalities. And these are still the basic hallmarks of dystonia. So Now, in the early years, even before Oppenheim described his cases, these were 4 cases, all children. They were all Jewish, and they came from Eastern Europe, from Galicia and Russia. His particular cases were not related. Besides the details of those 4 patients, he also described some patients from memory that he'd seen, also some Jewish children. But in the same year, there were other papers going on talking about families of dystonia. They didn't call it dystonia then, of this condition. So in the early years, I'm going to talk about how the definition of this disorder evolved. And the question came up, is this really a separate disease, or is this a syndrome of some sort? And is it psychogenic, or is it organic? This was a big issue, and not only in the time of Oppenheim, but since then as well. So even before Oppenheim, a famous English neurologist from London, Gowers, in his textbook, he described some children who have this very similar condition that Oppenheim was describing. But he didn't elaborate. It wasn't a long description. It wasn't a full paper, just a few sentences. But he called it tetanoid chorea. Tetanoid means from tetanus. Tetanus, of course, is tight muscles. So he was talking about the movements and the muscles being tight. And in France, Dystonia in 1901 described people who had torticollis, and also he called functional spasms. Lazinski in Eastern Europe called it hysterical gait. In New York, Ramsey Hunt, who was at Columbia, called it myoclonus of the trunk. And then in 1908, Schwalbe, who was then writing his thesis in psychiatry under the training of another professor there, Zien, saw some children with the same condition that Oppenheim was describing. And in his thesis, he wrote these 3 children up. They were siblings, malady de tics, tonic cramps with hysterical symptoms. So again, you can see the flavor. They didn't know what this was. They didn't have a name for it. And they didn't know what to call these kinds of movements. And because doctors, they don't see something before, they jump to the conclusion, oh, it must be hysteria. And so that had a connotation, and that was there for many years. By the way, I should point out that Dan Truong and I translated it from Germany. He spoke German, and I spoke English better than he did. So together we combined, and we translated Schwab's paper and published it in the Dystonia 2 volume, which was one of the symposia that DMRF supported. So this was a doctoral thesis of Schwab. 3 Jewish siblings, Fanny, Herman, and Wolf Levin. I guess in German that's how you pronounce it. They were from Lithuania. And Roswell Eldridge, in his review of 1970, mentioned that this particular family was reported at least 8 times in the literature. Schwab was the first, and Zien 3 years later, and then so forth. You can see the list. I don't have to read them out. And this was a picture from one of the papers of Wolf Levin when he was now 38. And they said the symptoms had actually improved. It turns out, if you read the description, he was treated with morphine and scopolamine. Now, scopolamine is an old drug. Actually, artane is related to scopolamine. Artane was developed based on scopolamine. So the drugs we're using today, they were using it back then. But it's just quite amazing how the world really hasn't changed, and it's still there if we go back and look at it. So looking at this as we keep going on, Zien himself reported the Lewin family again, and he used the name, this is the same year as Oppenheim now, 1911, called it torsion neurosis. And in Poland, Flatow and Sterling were seeing some families with this, and they called it progressive torsion spasms. So they used the word torsion then. And again, the twisting movements, but different names, and then, of course, Oppenheim. And when he suggested these 2 names, the name of Dystonia musculorum deformum was the one that stuck. Dysphagia lordotica progressiva was dropped, and everybody called it dystonia. And because he was such a famous neurologist, Oppenheim's paper was widely read around the world. And people now recognize, they saw this before, but they now had a name for it. And so we can see, as I will show you in another slide, how subsequent doctors in the subsequent years, that is, started to use the word dystonia. So Oppenheim described, again, the twisted postures, the bizarre walking with the bending of the torso, sometimes a rhythmic jerking movements, and then maybe over time getting fixed postural deformities if they were untreated. So in New York, Frankel had earlier called somebody hysterical, and now he recognized it was dystonia, and he says this was, the patient had rapid twisting, sustained movements. Ramsey Hunt, who had used the term hysterical before, myoclonus of the gait, now recognized was dystonia he was looking at. Mendel called it twisting axial movements, and one of the early American neurology textbooks now recognized were both rapid forms and tonic forms of people who had dystonia. So conditions, as you start learning more and see more and more patients, you realize the spectrum of what the movements look like are much more wide. Now the question came up subsequently, though, is this really a disease of its own, or is it really a syndrome? And that's because people began to recognize that some children with cerebral palsy had dystonia. And then Kinnear-Wilson, another famous London neurologist, famous after this paper, of course, named after him, reported in 1912 what we now call Wilson disease. And many of those children with Wilson disease have dystonia. And then the encephalitis epidemics occurred right around time of World War I, up to 1926. And epidemic encephalitis, a lot of these people end up getting post-encephalitic Parkinsonism, but many also got post-encephalitic dystonia. So here were some etiologies, disease pathology affecting the brain that actually caused dystonia. So as a result, the idea percolated in neurology that maybe all cases of dystonia are due to some insult to the brain, and therefore it should be a dystonic syndrome and not a disease itself. And that became a concept until about 1944. Now, this is just to go back to Kinnear-Wilson, very famous paper and published in Brain in 1912. And he was actually a neurology resident at the time. He saw these cases, he wrote them up, and he put this in as his MD thesis. And of course, he got a disease named after it. But just to show you, here are how they look before the symptoms developed. Normal-looking person, and here's the dystonic grimace in the limbs that develop in these children. Here's another one, a young woman, and another. And Wilson disease is treatable. The gene has been described. We knew even before the gene that these individuals accumulate copper. The gene turns out to be a copper transporting gene, and copper was taken in your diet. It's in all foods, and some foods are richer in copper than others, and they couldn't excrete it. Normally, copper goes through the liver and excreted through the bile duct and out in the intestinal waste. And these people could not transport it out. It accumulated in the liver, and from the liver it spread the kidneys into the brain, and you got Wilson disease and cirrhosis of the liver and so forth. Today it's treatable. You can remove the copper from the body, and you can even prevent it if you can do the gene testing on people early enough. Anyway, this idea, as I said, that might be a syndrome because of all these conditions was Ernst Hertz, who published a trio of papers back to back in 1944, and he resurrected dystonia as a separate entity in its own right. Now, Ernst Hertz is another interesting person, another refugee from Germany. In the late 1930s, of course, Hitler was in power already. Ernst Hertz, a famous neurologist already, got out, came to the United States. He was hired by Houston Merritt. He was the chairman when I was a resident in neurology at Columbia, and Ernst Hertz got a job as a neurologist at Columbia. And by the way, Houston Merritt, who was a Southern boy from North Carolina, but he had no bias in his bones at all. He hired a lot of German refugees, Jewish refugees, and the department became a very powerful, famous department in the United States in neurology. Merritt had a lot of foresight, and he went for talent and brains. And so he was really good. And anyway, Ernst Hertz was attending when I was a resident. I saw some of his patients there. Little did I know that I was going to be involved in dystonia. But his is a very interesting paper, and he described it. He used the term myarrhythmia to refer to the rapid spasms rather than just the slow movements that people have. And this is just a title page of the first of the trilogy of papers published in 1944. And by the way, Houston Merritt was the editor of this journal. So what did Ernst Hertz do, among other things? He also used EMG for the first time on these individuals who had dystonia. And he showed in a series of different combinations of muscles the simultaneous contractions of agonists and antagonists. That is, muscles that work in opposite directions, like your biceps, and the antagonist would be the triceps. And these would be contracting simultaneously in the limbs, in the trunk, wherever. And he did these EMGs, and he showed, here's the biceps and the leg, the femoral muscle, and the quadriceps. Here's the extensors and flexors of another set of muscles, and so forth. And so that's a hallmark. And if you heard the paper this morning, and these animal models, these mice, he used the definition of synchronous simultaneous contractions of agonists and antagonists as a way that he defines these mice as having dystonia. And that started way back with Ernst Hertz. And in his paper, by the way, he showed another movement disorder, chorea, like in Huntington's chorea or Sydenham's chorea, that there's no agonist and antagonist simultaneously contracting, just the agonist. Individual muscles, short bursts, and only by random chance are there simultaneous contractions. So it just happens to be by random events in chorea. But the standard procedure in dystonia. Well, other people got into the act. The famous neurologists in Boston began to define dystonia as fixed attitudes, and they had nothing to do with movements, and that was certainly discarded by a lot of us. And then Zeman and Dyken, neurologist and neuropathologist in Indiana, did a survey in the state of Indiana of all dystonia. And that day, dystonia was considered generalized dystonia, just like Oppenheim described it. Oppenheim did not describe focal dystonias. They weren't connected together with generalized dystonia. And so he used the term general dystonia and made a survey in the state of Indiana. And he called what we call focal dystonias today as forms fruste, that is fragments of dystonia, and he wasn't considering them. And I'll show you this table again, but I just want to point out the paper in Indiana, 1 out of every 200,000 people in Indiana had dystonia. That was from their survey. Well, we're going to move now from jump from the 1944 of Hertz and then the 67 paper of Zeman and Dyken to 1970. Roswell Eldridge was a neurologist and a geneticist working at NIH. He got interested in dystonia. He went to see the people who were operated on for dystonia by Irving Cooper in New York, who developed a surgery for dystonia in those days. And he looked at these patients, and he began to investigate the literature and the reports. He did a big review, and this was a major review article, 78 pages long, in the Journal of Neurology. He showed many different pedigrees, and most of these patients came right out of Irving Cooper's patient population. He showed that some families were autosomal dominant transmission, but most of the Jewish families were not. There were no 2 generations involved, and he thought that the Ashkenazi Jewish population were autosomal recessive. So this was in 1970. He was the first to suggest this. Another thing he did, he looked at Cooper's patients that time, and he said that about 52%, when they first came to Cooper, so out of 44 patients, 23 were diagnosed as hysteria, or what we call psychogenic today. In 1974, Marsden in London looked at his population. He found it was 43%. In Cooper's large series, he himself, in his paper in the 1976 paper, which came out of the first Dystonia Symposium I'll be mentioning in a minute, he said it was about 25%. We did our own survey independently in our population in New York, and we found about 44% had a prior diagnosis of hysteria or psychogenicity. So that's how it was misdiagnosed. Fortunately, after all of this and the DMRF being found and so forth, it's rarely missed today as psychogenic as it was at one time. So this brings me now, we're in the 1970s, and I'm going to talk about the first International Symposium on Dystonia, which was held in 1975. This was the brainchild of Martin Sloat. He was the father of one of my dystonia patients, and he wanted to do something for dystonia, just like we heard about the Belzbergs wanted to do something about dystonia. Marty came to Eldridge and to me and said he would raise funds. Could we have some kind of get-together, a conclave to study dystonia, bring people together, and asked if we would put it together, and Roswell and I did that. Marty raised all the money. Fortunately, his sister was a very famous Wall Street broker, and he had a lot of other friends on Wall Street, and they raised the money for this themselves. We held it in a Manhattan hotel in the late spring of 1975, just before I was going to go on my sabbatical. And many important presentations were there. I'm going to show you the title pages of some of these. And as I was preparing for this talk, I decided to look at that symposium again and see what was there. It was really amazing. When word spread around and we announced it that we're going to have this, people we never even heard of before wanted to come and present papers. And a record-setting thing, mainly because I was still on sabbatical, I had time. We could edit the papers, and we got the book published 1 year later in 1976. And in that symposium, I decided we need a new definition of dystonia, and we called it sustained involuntary twisting movements that could be fast or slow. And that was in the opening paper, that, as you see here, in this paper. And in this paper, we also recommended that the condition should be called, instead of dystonia musculorum deformans, not everybody goes on to become deformed, and it's certainly not a muscle disease. Let's call it torsion dystonia. And the movements themselves or the posture would be dystonic movements, dystonic posture. So we try to separate the disease with the movements in that sense. So this was the first symposium, and the title page, and I already mentioned this. And just to highlight a few things, for example, the first report of the special dystonia in the Panay Islands in the Philippines, X-linked, only affecting men, was reported at this meeting. We now know this dystonia as Lubag or X-linked dystonia Parkinsonism. It's DYT3, the gene of this has now been found. First reported here. Here was a paper of Dopa responsive dystonia. It was a family, 3 affected individuals, 3 generations from 2 neurologists in Columbus, Ohio, presented this paper. And the very next paper presented in the symposium was by Sagawa. Sagawa was from Tokyo. He had already seen this and reported in Japanese this condition called hereditary progressive dystonia with marked diurnal fluctuation. But the highlight of this, and he had many little small families, is that they all respond to low-dose L-Dopa. And it was one of my fellows who coined the term, let's call it Dopa responsive dystonia, because that highlights it. It highlights the therapeutics of it. It stands it out. And this fluctuation, diurnal fluctuation, is not a critical factor. The fact that they respond to L-Dopa, and now the gene for that is known, and we know why they respond to L-Dopa, this, it all makes perfect sense. And so this is now in the lexicon, too. And then David Marsden's very important contribution, tying in these so-called, previously known as form frusts of dystonia, these so-called focal dystonias, as part of the dystonia spectrum. And it's not just generalized dystonia that's dystonia, but the isolated dystonias of adult life adult onset idiopathic torsion dystonia. He calls it the blepharospasms, the oral mandibular dystonias, the writer's cramp, the torticollis, the axial dystonias. He's lumped them together in one condition, and this was another major contribution that came out of this symposium. And to this day, this is all part of it. And of course, as you probably know, this is the most common form of the dystonias. And many of these are probably different genetic diseases, and I'll show you. We'll come back to that in a minute. Another paper that was of interest came out of NYU. The neurosurgeon Batista was making lesions in monkeys, and in the midbrain he found a place that he could make a lesion, and he was able to get this kind of torticollis phenomenon. And then, of course, in that symposium, Cooper presented his 20 years of follow-up of his neurosurgical treatment of, and he still called it Dystonia musculorum deformans in that day. Okay, so as I say, we now can add the subvocal and segmental dystonias as part of the dystonia spectrum. So that brings us up now to 1976, and the event of that year, of course, was the founding of the DMRF. When I came back from my sabbatical in Paris, Marty Sloat contacted me and says he wanted to let me know that some couple from out west, I don't know if he knew where you were from at one time, is coming to Washington, and he's interested in starting a Dystonia Foundation, and he asked if we would come down to meet with him and his wife. And of course, we got on the plane and we went and we met in Sam and Fran at that time. We went into your hotel room. You had a suite. I think it was your living room suite. And we're all sitting there together, and you talked about your ideas for the foundation. And that's because Sherry had come down with that diagnosis of dystonia by John Menkes at UCLA. And you wanted to do something about it, as we already heard today, but I'll repeat now, founding a foundation dedicated to this. And John Menkes was Sherry's doctor, and he was selected to be the first scientific director, which was fortunate because he did one really important thing, which I'll tell you about. But this was the beginning, and I was asked to be on the scientific advisory board and put the board together with John, and then, you know, the history of the foundation since then. And here we have Fran and Sam at one of the meetings. And when his term as president ended, the Kesslers, Dennis Kessler became president. Here's with Barbara. We all look younger at one time. Well, it's nice to look back at those pictures. And I don't have the third president, the Lewises, but anyway, we'll have to get those pictures coming up. But here's John Menkes. He was scientific director for 10 years. And then Charles Markham took over, another UCLA neurologist, was scientific director for 20 years, and then Malin DeLong became scientific director in 2004 until today, still president, scientific director. And I thought this is the three stooges, what do you want to call them? Anyway, the three old wise men all standing together in a nice pose. So what was the purpose of the foundation? Was really to emphasize they wanted to do research. Sam and Fran said it's got to be about research and not patient care, and that was it. And so the word research got into the name. It wasn't the Dystonia Foundation or Dystonia Medical Foundation, it was Dystonia Medical Research Foundation. As I say, John organized the scientific advisory board, solicited grant applications. He also had the idea of, which was a good one, as I tried to mention before, of making sure the board of directors there, watching the review, getting young people involved, rotating the scientific advisory members, and so forth. The first grants came in 1977, and I remember those early days, the grant applications were extremely weak. They weren't considered worth spending hard developed money from the foundation on such mediocre research. We decided not to award those grants, and I know the board of directors was very frustrated. They had the money they wanted to spend for research, and why aren't we getting research? But we didn't want to waste your money, and we held out for better and better applications. And So, but it was a frustrating time in those early years. You may well remember them, Sam and Fran, how we talked about all this. But eventually, we got the grants, and moreover, during this time of a few years now, 4 years later, the idea came to Sam and Fran that let's start some centers. Maybe that's a way to get research going. If we just found and formulate and support some research centers. So they had a competition, and 3 research centers came out of that competition. Ours in New York, David Marsden had one in London, and then Donald Collin ran the one in Vancouver. And that's when really research started taking off, and we got fun. And I can tell you in our center, I had money for one fellow, and Dystonia fellow, and the first person I hired for that job was Susan Bressman. Susan was one of our residents. I saw she was a dynamic, assertive resident. I liked her attitude of doing things, and I knew she was very smart, and I asked her I have the money now, would you like to be a fellow? And she wanted to, but meantime, this came late, and she already signed on to be a stroke fellow with Fred Plum at Cornell. And I don't know if you knew Fred Plum. He was a very hard, tough guy who doesn't take nonsense from anybody. And he was really, she had to face him to tell him she's not coming. And he didn't talk to me for several years, but then we became friendly again. And then we've had good fellows ever since. We've had many excellent fellows in the field of dystonia and other movement disorders that work with us. And a lot of this was attributed to the fact that we had that center grant from the DMRF. Well, by 1984, the view was, well, we don't have a real still good definition. Let's have a task force, and with a simple assignment, come up with a definition of dystonia and some kind of a classification. And so a task force was founded. The 3 heads of the dystonia centers were part of it. John Menkes was scientific director. And then Andre Barbeau was a movement disorder neurologist in Canada. And Fred Wooten, who had done some biochemistry research when he was at NIH on dystonia, were all asked to join. And we together came up with a definition of dystonia. And we had a difficult time because we knew sustained postures had to be part of the definition. That's the hallmark of the movements in dystonia that differs from a tic or differs from myoclonus or tremor. So we had to use it, but not all sustained postures are dystonia, so we had to distinguish that. And it wasn't only sustained postures, there's other kinds of things that were seen in torsion dystonia, so we had to take that into account. I already mentioned that the faster movements were called myarrhythmia by Hertz, and so we had to come up with some terminology. And we came away with a single sentence. Dystonia is a syndrome of sustained muscle conditions, frequently causing twisting and repetitive movements or abnormal postures. In terms of classification, the classification that Roswell Eldridge and I put forward were primary and secondary dystonias, and we wanted to use that again. But Andre Barbeau said the French will never understand primary and secondary. To them, secondary means it's lower class than primary, whereas secondary to us means it's a result secondary to a brain insult, like trauma or Wilson disease or cerebral palsy, encephalitis, and so forth. And so we wanted to use this, but the English terminology, but no, we ended up bowing to the French francophones and called it idiopathic symptomatic, and that was how it was called and at that time. So this was the definition. The first sentence is the same as I said before, but I added another sentence later on because a very common feature, dystonia can be activated upon if you do some other activity movement or in the same limb. If you move that limb, the dystonia will get worse. That's a very common feature, so I threw that into a 2-sentence definition. And you may have heard a committee was formed about a little over a year ago that met a few times and led by Alberto Albanese. and the DMRF played a role, and the committee came together to see if we can come up with a better definition and classification scheme, and this is the final result. This submitted, the paper was accepted, it will be coming out in a few months, there was just a few words changed. There was a new term, intermittent, added on. And in the previous definition, the word abnormal was in front of postures, and this was word twisting, causing twisting, repetitive movements, and postures are both. And we changed it, we put twisting down in this sentence. So there were 3 sentences now, from the first one and then 2. So now dystonic movements are typically patterned, which means the same muscles over and over again, twisting and maybe tremulous. And dystonia is often initiated or worsened by voluntary action and associated with overflow muscle activation. So it's a 3-sentence definition now for dystonia that will come out. Now the DMRF was also very instrumental, not only in giving grants and setting up these consensus groups, but developing other symposia, and I was asked to organize them, and for the one that came 11 years after the 1975 one, we held in Arden House, a property of Columbia University, in the woods, about 50 miles away, and a bus ride from Manhattan to there. I asked the other 2 heads of the dystonia centers to join with me, David Morris and Donald Collin, and we edited this volume. And then another 10 years went by, and the 3rd Dystonia Symposium came. By that time, Malin DeLong was now scientific director. So David and I and Malin put this one together. That was held in Miami. And the 4th one, 5 years later, there's so much going on in genetics, it was decided by the foundation to have another one, and we had the 4th one in Chicago. And again, it was now David had died, and we asked Mark Hallett to take his place, so Malin, Mark, and I put that one together. And then 10 years later, last year in Spain, I think it was the European Dystonia Federation that wanted to have a symposium, and they invited, I think, the DMRF. I don't mind have that history correctly because I wasn't involved in the planning of this one. But Jan was there. I think you were heavily involved, and Buzz Jenna was involved, and Malin was involved. So with the Europeans, and this was went on, and exactly 100 years after Oppenheim's paper. And the proceedings are going to be published in an issue of Movement Disorders, in which also this new definition I just showed you will be published as well. Okay, other things that the foundation played an active role in. So let's go back. Here's Zeman and Deichen with the first one, but as I told you, it was well known by neurologists that most dystonia was occurring in children of Jewish descent, particularly the Ashkenazi Jewish population. And in Israel, where they have mixed populations of Jews from not only Eastern Europe, but also the Afro-Asian Jews, they did a survey of dystonia, again, using the definition of generalized dystonia. They did not consider the form fruits. They did not consider the focal dystonias, in other words. And they showed that actually the prevalence in Eastern European Jews was 1 out of 15,000, many more than Indiana. Indiana must not have any Jews. That must be why there's only 1 out of 200,000. And the Asian Jews, the Afro-Asian Jews, are 1 out of 117,000. Well, the DMRF at that time was very curious. What is going on? What's the right definition? If we don't know how many people have dystonia, how can we ask for money from the government and for raising funds for dystonia research? And they decided, and I think I was part of that deliberation of the science committee, let's get a contract out to somebody who would get the information from the Mayo Clinic. The Mayo Clinic in Olmsted County, Minnesota, has a record of every single hospitalization of anybody in that county, even if they're not a Mayo Clinic patient. So they have really good medical records of every citizen in that Olmsted County. And they know what the patients have. They have a great database system. And Jay Nutt had mentioned to me earlier that he was interested in taking a half-year sabbatical and going to Mayo Clinic and doing some work. And I suggested his name if he would go and do this. And he went to Mayo Clinic and came out with the prevalence rate. 2 individuals in Homestead County had dystonia, prevalence of approximately 1 out of 30,000, and whereas the focal dystonias were about 10 times higher. And even to this day, I was having dinner with him. I was invited to Portland, where Jay is located, and we were chatting at dinner. He still remembers this paper. He says, that's my most commonly cited paper to this day. The prevalence rate of dystonia, that's a very classic paper now. And in New York, we were seeing most of the Ashkenazi Jewish patients, and Neil Risch, who we worked with, this great population geneticist, came up with the idea of figuring out what the prevalence rate is. It's about 1 out of 6,000 Ashkenazi Jews, but since the gene is expressed in only about a third, the gene is prevalent in about 1 out of 2,000 individuals of the Ashkenazi Jewish population. And then other countries, here's Japan, here's North England, here's the European thing, and there's many other papers on epidemiology. And you can see they're probably around this set of population. Many fewer generalized, many more focal dystonias. So this is the J. Nutt paper that was published. And let's classification. This has changed with time too. This is our original classification in the 1975 Symposium. Primary and secondary, we put a third one called psychological, or psychogenic today would be called. And the primaries are hereditary or sporadic, and they could be focal, segmental, or generalized. And the secondaries are due to some other disease, either hereditary disease, let's say Wilson disease, Huntington's disease, or some environmental illness, trauma, encephalitis, stroke, whatever. Okay, we saw that earlier. And I think I showed that earlier, so let's move on. Finally, the original publication of the consensus meeting was published in this paper. And again, the 3 heads of the Dystonia centers put this together. We did this major review article in 1987. This was the classification scheme then. 3 parallel things by cause, by age at onset, and by distribution of the body. Here's the focals, and here's the generalized, for example. And age at onset is very important because they tend to be the ones that get the generalized dystonias. Their average age onset is about 7 years, and the older onsets tend to be focal or segmental. And nowadays the classifications look like this: age, distribution, and etiology. And in the paper, I think it was the Miami meeting, we put together a classification separating out primaries into dystonia plus syndromes, meaning other neurological features besides dystonia will be present. So Dopa responsive dystonia, for example, is a dystonia plus. It has features of Parkinson's. Myoclonus dystonia has feature of myoclonus. They're still not degenerative. Brain cells don't die, just like primary dystonias, that brain cells do not die. But here the primary dystonia has only dystonia and nothing but dystonia, and dystonia pluses have dystonia plus something else. And then we still have our secondary and our heredodegenerative diseases, and we still have diseases in which dystonia can be another feature, like Parkinson's and so forth, and you can get dystonia. So another big event, of course, that the DMF sponsored was genetics. From our Dystonia Clinical Research Center in New York, we saw all these patients, and one of the highlights that we put into our proposal and why we got our funding was to start working on the genetics of dystonia. And we didn't have a good geneticist at Columbia. I couldn't recruit somebody, so we turned to Xander Brakefield at Harvard, and her graduate student at the time was Lori Ozelius. And here's the then president of the Dennis Kessler was with them in this photo. And it took a number of years, as some of you know, but they cracked it. They found the gene for what's called DYT1 dystonia, Oppenheim dystonia, prominently but not only exclusively affecting the Ashkenazi Jewish population. It's in all parts of the world today, just more common than the Jews, that's all. So how do we work on this? How do we get this? Well, it's because Roswell Eldridge in 1970, remember, was looking at all these families. He was interested in genetics of dystonia. He came up with his idea, which was wrong, that the Ashkenazi Jews are recessive, and the non-Jews were dominant. We showed that to be wrong. Everybody is dominant. But we took his pedigrees. He gave us the names, and we went and tracked them down. And the largest single known family of dystonia in the world lived in, I think it was Maine and Quebec. It was French-Canadian people that lived there. They had a big population. And using that big family, we mapped the gene to the chromosome 9q34. And then Neil Risch had this great idea. Although we didn't have any big families of the Ashkenazim, we had a lot of small families, and we can pool them together, think they all had the same gene anyway. Let's do that, and by bingo, we found the gene. And that's, as I say, was the DYT1 or TOR1A gene, it's called now. Beating us to finding this gene, however, was DYT5, dopa-responsive dystonia. The Japanese found this before TOR1A was discovered. They went right to it. The Japanese workers had been involved with biochemistry of dopamine and norepinephrine. They knew what the enzymes were, and they looked for them, and they found them. So today, we have DYT25. Now, we started with 1. And this is rather amazing. In parentheses are the names of the genes that have been discovered. A number of these, we don't have the genes yet. And you can see, I put down, to make it simple rather than chronological, these are the primary dystonias in the DYT labels. Here's the dystonia pluses. Here's your dopa-responsive dystonia. Here's your mild clonus dystonia. Here's that rapid onset dystonia Parkinson that our speaker today was talking about, DYT12, and so forth. And what the geneticists, though, did, they got mixed up, and they put in even the paroxysmal dyskinesias, they gave them DYT labels. So I had to separate those out. And of this list, only this Filipino Lubag DYT3 was the only heredodegenerative disease in this listing. Just to highlight, in the last 12 months alone, 4 genes were discovered. The gene for DYT4, which is an Australian gene, Australian family, and then these 3 genes were reported in this past 12 months. That's, we're not through yet. Next year, who knows what the number is going to be. It's not going to take one, it's going to be more than one slide, though. That's the problem. You're a lecturer, how to fit it into your talk. But anyway, let me close with a very famous statement by somebody. Without the DMRF, dystonia research would have been virtually non-existent. So thank you very much. I'm glad to be a part of it. It's been a fun trip, and it's not over yet. It's really going to be exciting, and we all like to live long enough to see the end of it someday. But thank you for having me speak with you.